All right, well, we're going to move on now to some adult cases. And the general format's going to be, as we've seen with Andrew, that we're just going to present an outline of, these are real cases, mostly in the last few weeks and months that we've all faced personally, a bit of a background, some screen traces about what we were looking at and some of the decisions that we were trying to make, and we're going to share these with you and try and find out what the decisions were that you would have made as well. So this is a case that I was faced with recently, craniocervical decompression, which is just really just a bit of an orthopaedic operation just to decompress the cerebellar tonsils. And this was a young woman, interestingly, I only saw just before the surgery, and a couple of issues. Firstly, she was getting a quite inappropriate narcotic regimen for her pain, including going to see her GP once a day and getting injected with a single shot of 60 milligrams of morphine, taking a lot of oxycodone, but was absolutely petrified of awareness for no real reason that I could glean. The operation is prone and is not particularly special, but I was very much mindful of the fact that this lady was likely to be opioid tolerant, and I didn't think that awareness was going to do her any good and probably not me any good either. So the sort of anaesthetic I gave wasn't a typical one for me, it was fairly generous. So we used nitrous oxide, quite a lot of sevoflurane, quite a lot of fentanyl. She was paralysed, and this is what I faced. Now, it's a bit complicated, but this is the BIS. It started off sort of below 40, and even then I wasn't happy, and I took it down and down and down, and that would probably concern Kate and Dan Sessler as well by the sound of things. We had lots of nitrous oxide, we had lots and lots of sevoflurane, yet I still had a heart rate of 120, I had a blood pressure that was quite reasonable, and although it doesn't show here, this lady would breathe on occasions if she wasn't paralysed. So I wasn't really sure what to do next. So I wonder what you would do now, and the question I would put is, would you do nothing and just stay the course? Would you increase the opioid and reduce the sevoflurane, because the BIS of course is 21? Would you just increase the sevoflurane further, add more opioid, or add some clonidine? So I'd be very interested in hearing other people's opinions, so if you could vote now. Right, checking your email. Well, that's universal to just about every case, so that's okay. I didn't have a registrar. So look, we're not 100% sure what you all think, so I'm going to direct the answer to my esteemed panel over here and ask what a volunteer over there would do in this circumstance.
I can volunteer. I chose number 5, clonidine. I think you did great work adding the nitrous oxide, not so much for the awareness, but for potential to prevent progression to chronic pain or ameliorate that. And with the high heart rate and high-ish blood pressure, I think you need more sympathetic nervous system ablation. So clonidine, I think, is going to do everything: sedation, analgesia, and sympathetic nervous system work. So that's my answer.
Would anyone care to suggest an alternative option? Is there another argument or something else we should be doing? I mean, this was quite unusual. This is an unusual lady, but I have to say my medico-legal defensive antenna was up. This was a woman who was going to need a lot of drug. She was tachycardic. This wasn't an easy operation to know what she was doing. Couldn't see her pupil size. She was prone. It made me feel slightly uncomfortable. I was very glad I had the BIS monitor, to be quite frank, because at least that gave me some assurance, and I was quite seriously thinking about, well, at least I've got this number here, and if I ever had a problem, well, you know, I can take photographs of this to show what I did, which I did. But it's not that uncommon in my experience, and maybe it's the case mix I deal with, that we do have people that aren't behaving normally to what I would consider a normal dose regimen and a normal quantities of drugs. So it'll have to remain a mystery what everyone else in the room thought about that one, but we might try and move on. Now, this was an unfortunate case. Again, I did recently. This was a young girl who was in a car accident, unfortunately tore her aorta and needed a stent, and almost certainly had major neurological loss as a result of that. But she hadn't had a head injury. She'd been ventilated in ICU for a day or two, responding perfectly normal, so tolerating a tube well, but responding to complex commands very well. And unfortunately, she also had compartment syndrome, as you can see there, and she needed to have major tissue debridement. I wasn't sure how much sensation she had in her legs. So the sort of anaesthetic I gave was some sevoflurane. She had quite a lot of fentanyl. She was paralysed. But again, I faced something that was a little similar to the previous case. So if we look down here, this is the BIS. We can see it was low, and I'm clearly a very conservative anaesthetist because I took it down even further. There were some occasions when there was EMG artifact, which is what this red is, but there were plenty of occasions that wasn't there, and it didn't really seem to change the signal that I got. I was pretty comfortable that the trace reflected what I felt was a good depth of anaesthesia, but again I was faced with hypertension, I was faced with tachycardia, and you can see this woman was breathing a lot. She probably didn't have sensation to her legs. She had no reason to be tolerant to opioids and had quite a generous dose. So I was considering then what I would do in this circumstance. So I'd be interested to know what treatment you might consider instituting, ranging from increasing the sevoflurane, decreasing it, the BIS is 28, adding more opioid to my 600 marks of fentanyl, again clonidine, or doing something else. So I'd be interested in your opinions if you're happy to vote on that now. Okay, so I suspect this isn't very different to the response we might have got from the previous question. Some people would increase the sevoflurane. No one would decrease it. Adding some form of analgesia, and I guess clonidine produces some sedation as well, would seem to be a popular option. I'm not sure if it's just me that seems to get these cases, but I'd be interested, again from our panel, do we see much of this, or am I just dealing with an eclectic sort of mixture of patients that don't seem to behave the way I would like them to with the anaesthetics I give?
The more you look, the more you find of these sort of situations. I mean, can you imagine if you gave this anaesthetic without the information from the EEG? The EEG clearly is kind of guiding you as to how much hypnotic and how much analgesic you want to add. And you can imagine that might be exactly the sort of Cessla case.
Guy, why do you think you had such a low BIS with such a low amount of sevoflurane? And did you titrate the sevo down against the BIS, or did you just think, I'll just give a really low dose of sevo in this patient?
No, this was titrated down. I had the BIS on from the start. I really wasn't quite sure how much sensation this woman was going to get. There was this question about a cord injury, which was very likely, so I really didn't know what surgical stimulus she was going to get. They were operating on her lower limbs, so I had the impression that she wouldn't need a lot. And you know, she wasn't all that well, so I actually put this on for that very reason. But she didn't need a lot at all. But I also got the impression that this was an uncomfortable experience, to use a very unscientific word. Her respiratory rate was quite high, and she did appear to respond to the surgical stimulus. So my uncertainty was, you know, what sort of nociceptive input was she going to have, and that was what triggered me to put this on. The sevoflurane came back to low levels. She didn't have residual sedation from ICU. So yes, I was working in a slightly uncomfortable space with a pretty low dose of sedative hypnotic, and so I just wasn't 100% sure whether I was giving enough. And what I chose to do in that circumstance was add opioid. I was just a bit worried about blood pressure for a couple of other reasons, so I didn't want to go too much near clonidine potentially. But I didn't increase or decrease the sevoflurane, so I relied on that number to say to me, I think that's an adequate degree of sedation or hypnosis and that I won't go near it. So no, that was a deliberately low dose, but I was a little uncomfortable at times as to whether that was enough for this patient.
Because the trace looks sleepy after Jamie's talk, doesn't it?
Guy, both cases are significant trauma, obviously sick patients. What was the state of the autonomic nervous system before induction? Were these patients in fact tachycardic at that stage? Were the hemoglobin levels normal, etc.?
No, they're all good actually. Jim, I think it's a very good question. The first one was actually an elective case, and she was off the street and fine despite an interesting sort of pre-operative dose regimen. This one was actually, she'd been in ICU for a couple of days. She was well sorted out hemodynamically, hemoglobin-wise. She wasn't septic. She'd been pretty stable. So this was unusual, and I took a lot of note of the respiratory rate. I didn't take note of the pupil size, or if I did, I haven't recorded that, but I think that would have been useful information as well in someone who's opioid naive. So, but no, I didn't think there was anything sinister going on.
And I think, Guy, this is where we're hitting the very issue that gets audiences to come along to this sort of talk. If we lift the BIS trace out of it, on the face of it, that patient needs more opioid. You'd think the anaesthesia was light. So what is the seductive element here with the BIS? It is tempting to think we need to lighten the anaesthesia if you just rely on that number. Yet, as Kate says, when you look at the trace, things look okay. Good case.
Yeah, and if I hadn't had the BIS, what would I have done? Well, I wouldn't be using 0.8% sevoflurane. I suspect I might have run into some hemodynamic challenges and probably had some vasopressor and so on, so I would have potentially brought into a different scenario.
Can I make a point about deep BIS values at this point, Guy?
Please, Kate.
I hope I made it clear that the data are observational and it's speculative at present. The only thing one could say with certainty is giving too much anaesthesia is wasteful of money. So that a number like 28, my tendency is to lighten that patient up to around 40 if I can. But in a young person without ischemic heart disease or another, significant older person comorbidity, there's no evidence that deep anaesthesia is bad for them at present.
I've heard a couple of comments about the fact that the trace looks like we'd like it, and that's true. Can I ask, not all machines have traces available by default, or sometimes the speeds mean that you can't see them very well. Does anyone in this panel use EEG without the trace, and do they feel they get rich and useful information from it?
Sorry, EEG without the number?
Yeah, without the trace. Does anyone use BIS or entropy and have the number up in the little box down the bottom? Because to be quite frank, sometimes there isn't room on the screen for the trace and something else has to drop out.
I always have the trace. Jim?
I've always had the trace since I read Jamie's article on what he was doing at Waikato.
I mean, it's the same as all the other monitoring. I mean, would you just look at the heart rate without the ECG trace, or the capnograph without the capnograph trace?
We did an interesting exercise the other week when I had a case with 6 screens of everything, and I took all the traces off and made them all numbers. And the trainee was very uncomfortable, as was I actually. And I said, well, which ones do you want to have back and why? And of course they wouldn't have a capnograph number without the trace, and they wouldn't have the arterial line without the trace, they wouldn't have the ECG heart rate without the trace. But certainly the EEG was not a high priority because we'd run out of screens, and it's very interesting to hear the talk today that it does seem to be a very rich source of information. Look, I think we might move on. So now Jim Bradley, I haven't introduced to date. Again, I don't think Jim needs any introduction to this audience. Jim has had an enormous influence in this society over the years, and Jim is a very, very experienced clinical anaesthetist. And I have to acknowledge that some of the ideas around having these sort of interactive sessions and getting information from us as a group was lifted from Jim's session that he organised from the NSC in Darwin, which I think was very helpful. So, Jim, thank you for joining us. And are you happy from your seat there just to work through this case for us?
Yes, I think we can do that. Guy, I started training in anaesthesia a long time ago. My first solo general anaesthetic was given up the road at the Royal Hobart Hospital, and I can tell you the anaesthetic options were pretty limited back then, but at least in Hobart you were allowed to use halothane to make sure the patient was asleep, and you had a decent fluid tech vaporiser, but you had no idea, of course, of what was really happening with the kinetics. I've, ever since the modern ethers came along, been a very happy volatilistic, unless I'm caught up with a case where I really need to avoid volatile agents or even occasionally muscle relaxants, in which case I always use BIS. But for most of the time with adult general anaesthesia, which occurs in daylight hours, which is how my practice is structured, I'm happy just to dial up something around 0.7 of a Mach plus. Don't understand how nitrous oxide works into this EEG business when we follow the eager approach to the total Mach score, but that's another area. But I am interested in fact, using BIS to see if I can better sedate people, or to do what I think is sedation in people who would usually have either minor procedures like the gastroenterological ones, or sedation supplementing major regional anaesthesia. So my second case will deal with that latter scenario. In the case of gastroenterological sedation, there's not much point putting a BIS onto someone having a gastroscopy, because the case will be finished usually by the time you've had a chance to look at the number. But if you're doing a gastroscopy and then a colonoscopy to follow, you do have the opportunity to see what you might be achieving and how the patient might be travelling. So with that background, the situation here is of a case a few weeks ago, a 76 kilogram, 49-year-old woman having a colonoscopy plus gastroscopy, expected duration around 20, 25, perhaps 30 minutes. This was conducted at the Wesley Hospital. There's a tiny little shot up on the right-hand side that shows that I get to wear a pink shirt when I do these procedures, and I don't even have to scrub, all very pleasant. I'm not sure that my hands are in the pocket, but it may be to stop me fiddling with anything while the case is proceeding. At any rate, we know from institutional audit at the Wesley Hospital in Brisbane that almost all anaesthetists give 2 to 3 milligrams of midazolam, 50 to 75, occasionally 100 micrograms of fentanyl, and propofol often around 40 to 60 or 70 milligrams to start, and then boluses as indicated by patient movement, or perhaps just a visceral feeling that it's time to give a little bit more propofol because redistribution has occurred. So not unusual to see those sorts of total numbers for a gastroscopy plus a colonoscopy. So that's what's happened in this typical situation. Guy, the next slide, I think. So the BIS has been put on, and what we've got here is we've got the EEG trace at the top. We've got the BIS trend on the top screen, and we've got the EMG signal below, and we can see that it's around a 20-25 minute case, and the patient's waking up. So if we look at the top left, we can see a BIS of 87, but we've all learnt enough recently, and it's been reinforced this morning, to see that there's a high EMG input there. And if you look just in the middle of the EEG trace, you can see that it's a noisy, ratty looking trace, and I certainly wouldn't be trying to read too much into it at that stage. That's pretty much what I expected. If we go to the bottom, we can see that we've actually, where there's not too much EMG signal, in fact got a BIS that's gone down to about 50, yep, somewhere there. So in fact, you know, that's perhaps after a small dose of midazolam, some fentanyl, and 60 milligrams of propofol. There's probably enough signal quality there to say that in fact general anaesthesia has been produced in this patient, somewhat perhaps to our surprise. And then 20 milligram boluses as we go along. If we look at the signal quality. In other words, if we try to remove the EMG artefact, which happens when the patients are grimacing or wiggling a little bit during this sort of procedure, we can see again that we've got a BIS down around 60, you know, the upper level of what we would regard as adequate general anaesthesia for colonoscopy, which in this situation I've always believed I was giving sedation, as it were, not a general anaesthetic. So they're the points that I wanted to bring out as background to the questions that we're about to ask. And based on what I've just said, is BIS possibly useful in gastroenterological procedures? So the options would be yes. Yes, it just is. Yes, it might let us to administer lower doses of drugs, facilitate a quicker recovery. I don't think the issue of triple O's is arising in most of the patients we see here. It may be useful, but there's so much confounding activity, movement, grimacing, etc. going on that you can't read much into the number, certainly if you don't look at the EMG activity. No, it's no use at all, or no, things are happening too fast in these short procedures, whereas there's a lot of thing going on. If you look at the BIS instead of looking at the patient, you are, as I think Andrea Davidson said yesterday, trying to drive by looking out the back window, looking over your shoulder. So, Guy, I think the questions.
Thank you. So if everyone's happy to vote on those 5 questions now.
So when I first sent the answers through to Guy, which he may have edited slightly, I wasn't sure that there were any right answers in this particular case, and I think the audience response verifies that. I think I got the message across that probably it wasn't terribly useful if you were trying to produce stable sedation. So what do we have? Yes, it may enable a lower drug dose and a quicker recovery. Maybe. No. Yes, the pharmacokinetic aspects in question 5. Guy, they're pretty much the responses I thought we might see, and I think it would be good to give the panellists a chance to comment further.
Yeah, I mean, this issue about, I think there's a couple of things. I think, as Andrew made the point yesterday, the things are moving fast, and EEG doesn't necessarily move fast or anticipate ahead of time. A cruise control doesn't see the hill coming up in front of you, but it responds to when you slow down, for example. And this whole issue around interference and unusual signals creating challenges is also relevant here. I'm going to put the panel on the spot. Does any of them use BIS routinely? And Jim, do you use it a lot, or did you use it to help us out for this particular session?
Look, there are a couple of issues. One is, of course, we've been, as Kate well knows, we've been kicking around this whole topic for a long time, and I think we continue to evolve our position. I'd come to the belief that certainly at the hospital in which I do most of these procedures, gastroscopy is general anaesthesia without an instrumented airway. Now, I wasn't so sure about colonoscopy, but given that this study was coming along, I was interested in finding out a little bit more. We also knew that the anaesthetists who didn't follow this drug sequence tended to use a lot more propofol, and that's when we, and that is they were avoiding midazolam and just giving propofol. So we were just a little bit interested to see if we saw or would see anything at all if we used BIS in these cases.
Is there an item number for using the BIS?
There is no item number. Well, there may be. I'm not aware of it.
So Jim, will you go back and use it next week?
I think certainly in the older patients where I've been using it, I have found out that a 20 milligram bolus of propofol lasts a lot longer and produces a greater fall in BIS, or let's say a greater change in EEG activity than I might have expected. And I think we've just we've been spoiled by the relative stability and safety we see in these cases, and we've forgotten, for instance, in the older patients, that redistribution of propofol probably doesn't occur nearly as fast as we think it does, and we just get away with it because we're in a fairly safe situation.
Guy, I target moderate sedation for my colonoscopy cases, which I do once a week or a fortnight. And I've used the BIS a lot as part of research projects in this area, but I wouldn't advocate its use in routine work, mainly because even in a public hospital, it slows down the start of the sedation quite substantially while you wait for the sensor to check. And I don't think the benefits are weighed up by the expense and the delay to the case. And I warn my patients that they're possibly going to remember something, and they expect that to happen, and I reassure them that if they do remember something, they won't mind, because they'll be relaxed and so forth. And in our research project that we're doing currently with the BIS targeting high and low BIS values, nobody remembers anything anyway. I think one of the things that people could add to their list is a question in the recovery room is that, do you remember anything about the procedure? And then that will help people better get a feeling about what the appropriate depth of sedation really is. But I think it's worth people whacking one on from, just see what their route, everyone's got such a routine in this area, just see what BIS effects their routine has. It's very interesting.
So, Jamie, what does the midazolam do to the BIS?
Well, in those sort of doses, it tends to increase the beta power, and so as a pure drug effect, it won't reduce it. It will reduce it, usually reduces it to about 85 or something. But occasionally it will then precipitate natural sleep, which is kind of what you might see occasionally here. And so if the person goes to a natural slow wave sleep, their BIS can go down to 30. I mean, so I say the BIS is just measuring your cortical activity, not the depth of anesthesia. And when the surgeon stimulates them, it'll shoot back up to 95.
If we then start to get into more complicated areas like esophageal stenting or difficult ERCPs and septic patients, there may be more real utility with BIS monitoring in this situation, but I think I don't have any particular experience in that scenario.
And I have to say, Jim, like you, like Kate, I do some occasional scope lists. They are fast turnover, and I've barely got time to get the blood pressure cuff on and everything else sorted out before it's all over and done with. So I think it's pretty challenging very often in that scenario. Although it is interesting to note that I think from papers you published, Kate, looking at the effect of intravenous fluid boluses prior to colonoscopies, there is quite a lot of hypotension in these cases. We published some work a few years ago, and that was the sort of case where there was the most hypoxia and hypotension. But I don't think it's going to be a practical tool to help us deal with either too light sedation or probably too deep for the practical issues that we've been talking about.
Guy, practically nobody read my paper on that one or implemented its findings, which were that if you give fluid to older people having colonoscopy, if you give them a litre, it makes no difference to the incidence of hypotension. And if you put a litre up during the induction of sedation and run it during the case through a 22 gauge drip in the cubital fossa, you'll give about 100 mils. Mm.
But there was a lot of hypotension, as I recall?
Yes, there was.
Mm. All right, look, I think we might move on. This is something I think we've probably all faced. So, Jim, would you be happy to take us through this?
Yeah. This is an example of an anaesthetic technique that, again, I see a fair bit of in daylight hours in an inner-city private hospital. So it could be a hip replacement, a knee replacement, or in this case, a radical prostatectomy. But the The anaesthesia is a spinal, basically, with a general anaesthetic or sedation, depending on the circumstances. Certainly in the case of a radical prostatectomy, it's an endotracheal general anaesthetic on top of a single shot plus intrathecal morphine spinal anaesthetic. So in fact, the only analgesia given was the fentanyl that was given before the spinal or was performed, along with midazolam. Propofol for induction, in fact, it was an endotracheal volatile supplemented GA, as we'll see in a few moments. Did I know the spinal anaesthetic, given what I'm about to tell you, was effective? No, I hoped it was, and I figured I'd find out at the end of the case. The relaxant was vecuronium. Clinical signs, adequate BIS about 30 minutes after induction. Vital signs quite normal. About 15 minutes after that, about 45 or 50 minutes into the procedure, when the surgeon is in the middle of his nerve-sparing prostatectomy in this anxious 55-year-old male, the patient almost sits up on the table. So the next slide, thanks, Guy. So there we are, that's about 30 minutes after induction, and it shows that in fact that I have picked up the message from the registrars who've all digested Kate's patient's papers very carefully, and I was not using nitrous oxide in this desflurane air and oxygen anaesthetic, and everything looks fine. And I think I must have been taking the blood pressure non-invasively, and it's displayed on the left-hand side out of view, but everything looks just fine. And if you go across to the BIS monitor on the right-hand side where we're displaying trend plus trace, that looks consistent with an appropriate level of general anaesthesia, and the trend shows that nothing very much has been happening, and that's what you expect really in general anaesthetics and major regional blocks where there's just a sustained but low-level surgical insult. Guy, if we look at the next one, if you go right over to the right-hand side, you can see that I have picked up the syringe of propofol, which is never far away in any case, and given 60 milligrams of propofol to this patient, who has then promptly laid back down on the table. And I've produced an isoelectric EEG with a BIS of 0.08. Nothing else has really changed anywhere through these 15 or 20 minutes and the subsequent part of the operation. And if we go to the next slide, here's the scenario. Surgeon has a very high opinion of his prowess in this particular operation, and if there were to be a major complication such as incontinence or similar issues, he'd have reminded me that the patient moved when he was deep in that part of the anatomy. So, the four possibilities: what would you have done when this patient moved grossly in this situation? Would you have given propofol, believing the patient to be light? Would you have increased the volatile agent, believing the patient to be light? Would you have given more muscle relaxant, believing the relaxant had worn off? Or would you have waited to see what was going to happen after the patient fell back into the supine position?
All right, so if everyone could share their thoughts with us. Okay, well, I think everyone's agreed with you, Jim, that reaching for the propofol, and I agree having it handy is always useful, is the thing to do. Some would have administered more muscle relaxation, because what I guess is what we've seen is that the patient's been travelling nicely with a BIS which is sort of 37, quite reasonable concentrations of volatile. Why did the patient move? I'm intrigued.
Jamie?
I don't know. I mean, you're moving on, forget about the EEG, you're moving on 1 mAc of desflurane.
You probably
Interesting, plus a spinal. So I think it must have been stimulation from the endotracheal tube. But what happens is it set off your motor parts of your brain, and your motor parts of your brain are quite separate in many ways. So the other situation is also true, where someone can be awake but not move and not paralyzed. So they're in a sort of sleep paralysis state. The motor systems up here are not able to be activated. That's kind of the inverse of what you've seen here. But I think you've got it. It's clear that everyone will have seen movements in apparently reasonably deep anaesthetised patients, although this does seem pretty extreme.
And your spinal was working perfectly too, I gather, Jim, post-op.
Well, exactly. We got to the end of the case, and to my relief, I guess, he was entirely comfortable at that point. I think the other thing that this demonstrates is a change in the way we practice these days. Certainly, if we combine general with regional anaesthesia, we give a single induction shot with muscle relaxant. That's so we can facilitate intubation. It's not for muscle relaxation anymore. And I think Jamie has answered the question for us, but the reminder is that we may see movement of what is an unparalysed patient if the right sort of stimulus is applied.
I was one of the 32% who paralysed the patient.
It's also interesting that you don't have to give a lot of propofol to get burst suppression if you've got a reasonable amount of volatile. And there's quite an interesting synergy that you get burst suppression with a very small dose of propofol once you've got quite a lot of volatile on board.
And presumably the patient didn't remember anything, Jim?
No, nothing at all. No, I think Andrew's comment, you've got a well-established GABAergic general anaesthetic there, and it probably doesn't need 60 milligrams of propofol to settle the patient down. Maybe 20, who would know, but it is interesting.
But you'll settle them down quicker with a bigger dose in that situation, obviously.
You betcha.
I think it's an interesting reminder too that, of course, what the EEG, what the brain is doing or what the BIS is measuring is that balance between what we give and what stimulus is occurring. And it's often graphic in combined general anaesthesia, regional anaesthesia, when things are sailing along fine, but when the surgeon or the stimulus is outside that area that the patient is used to, in this case, maybe it was the endotracheal tube or something else, then the game completely changes. So we've all seen that intubation, of course, the BIS goes down to whatever and you put a tube down and it goes way back up again. So it is that, very much that balance. And so if the surgeon or we intrude outside that regional anaesthesia area, I guess we're not surprised that we see things like this. All right, look, I think in the interest of time we might keep moving on. The cases get are more varied and more interesting, and there's some quirky ones towards the end. Kate, can you tell us about your road accident?
No problem. So this 25-year-old crashed his motorbike, ruptured his spleen, fractured his pelvis and had a mildish or traumatic brain injury. And he was having a laparotomy for the ruptured spleen, and he was on 2.5% SIVO. He'd had probably got out a 500 mic ampule of fentanyl, and he'd had most of that, and he had some rocuronium. And the next slide. And so this is after the incision, so you can see that his heart rate was 107, his BIS was 24, and you can see that the suppression ratio, I think that says 9, and you can see that towards the left of the screen there's some up and down bits, and then in the middle of the trace there's a flat bit, and then it looks like it's getting a bit more up and down. So that's the value of the trace. That trace is consistent with that number. And there's no EMG. See the red little EMG thing over the other side. And so his blood pressure is a little on the saggy side, and there's the entitled sevoflurane. So the next slide, what is the first thing you would do? So you might want to do more than one of these things, but what would be the first thing? Check the sucker bottle, decrease the SIVO because the BIS is low, give more opioids because the heart rate's high, watch and wait, give more fluids because the blood pressure's low and the heart rate's high. So we'll vote now.
Fluids, checking the sucker bottle, so I guess people are thinking along similar lines there in terms of we've got a volume issue. Some would decrease the sevoflurane, low BIS and quite a high concentration. Some would give more opioid for the tachycardia. Fairly diverse opinions. What did you do, Kate?
I looked in the sucker bottle.
And do you have a volume problem?
No, I didn't, which is interesting. So then I turned down the Sevo and gave more opioid at the same time.
So, Kate, if he has a traumatic brain injury, does the BIS work?
Well, that's a very good question.
And if he's got burst suppression, is that just his slowly expanding subdural?
That's also possible. We put the BIS on at the start, and for what it's worth, it was above 95. But I think I might defer, if I may, Guy, to Jamie on the issue of traumatic brain injury and the validity of BIS monitoring for hypnosis.
Yeah, certainly a traumatic brain injury with no anaesthetic can give you burst suppression. So that's one of the artefacts from within the head that you've got to think of.
So does that mean that if there's burst suppression with no anaesthetic,
yeah,
that you don't need to give an anaesthetic?
Well, no, that's just you've had a brain injury coma, but you probably do need to give an anaesthetic to suppress all the other sympathetic stuff that's going to go on. So you don't need an anaesthetic if someone's unconscious to stop consciousness, but you do need to give an anaesthetic to stop all the other sympathetic stuff, which I think we've got here with a heart rate of 107, I guess.
So this raises the issue of whether a separate issue, really, Guy, which is in a young man with a traumatic brain injury having a laparotomy. How do you monitor his brain? And the Brain Trauma Foundation guidelines would advocate some sort of intracranial pressure monitor, but this guy's Glasgow coma score wasn't low enough for that. I wasn't using the BIS monitor as a monitor for his brain injury. I was using it as a, let's see why he's hypotensive monitor instead. What would you do, Neuro? What would you have done?
What was the operation again? I've forgotten.
Splenectomy.
Shouldn't take all that long. I guess you're right. If the signs aren't there to start with, and standard recommendations suggest that the risk is low, I think I'd probably do exactly what you've done. I don't know whether I'd use a BIS normally in that circumstance or not. I guess it might be a source of concern for me in this case, of course. But yeah, I mean, statistically it's a low risk. How long had he been around? Been around for a while in hospital?
No, he came straight up from ED. I always use a BIS monitor in these big trauma cases because it helps sort out why they're hypotensive. That's the main reason.
If we get to it, there's another case later on which is a potential head injury and talks about almost the opposite scenario. So we might come to that at that point and see what we think.
I mean, I would say you decrease the Sevo, you should see the burst suppression go away in a few minutes. It's become pretty obvious. If it doesn't go away and your Sevo's at 0.5%, then you better start calling the neurosurgeons.
So Jamie, even if you do get burst suppression related to a head injury, you should still see tracking of BIS with sedative hypnotic agents?
Well, if the head injury is causing this burst suppression and you remove your hypnotic, you'd expect to see the burst suppression go away if it was due to the hypnotic. Okay. If it's still there and you've taken away your chemical cause of it, the conclusion is that there's a pathological cause of it.
Okay. Yep.
So another question for Jamie. So if this patient was actually 34 degrees because Kate hadn't been using her bear hugger, what would that be doing to the burst suppression?
It'll make you more sensitive, but you shouldn't get burst suppression at 34. You probably get burst suppression at, I don't know, 30 or something.
Guy, could I ask Jamie too, if this had not been a motorbike rider having a splenectomy, we probably wouldn't have been looking at the sucker bottle or thinking about the fluids quite as hard. So here's a case of an EEG trace which seems to perfectly fit the BIS score displayed. And the question is, do we, in this sort of situation, start to give almost a primacy or a higher value to the BIS in terms of how we manage. In other words, is question 2, decrease the SIVO, going to be the favoured option if it wasn't a motorbike rider with a sucker bottle?
Yep, yeah, I would decrease the SIVO.
We'll just give them some aramine. That'll fix everything up.
There's a thought.
Yeah.
I should have made that one of the options.
But that's an interesting thought, isn't it? I mean, forgetting the volume, we're happy with the volume, but the point is this brain still responsive? Can we decrease our set hypnotic and see if we get what we expect? If not, let's think about something perhaps more sinister. All right, well, let's move on. Kate, I think we're in the head this time.
Okay, so this is a every Wednesday scenario. 50-year-old woman with an acoustic, having a cranie. We went off to sleep with, started with 4 and 4 and then went to 5 and 5 and tubed her, and now we're back to 3 and 3, which is sort of where I generally kick things off in the pre-incision phase in a craniotomy. And the next one. So this will make everybody laugh. It's now 8:50, and we started anaesthesia at 8:20, and the incision hasn't been made yet. The heart rate's 59 with a blood pressure of 88. The BIS is 25 with a suppression ratio of 34, and you can see that the trace there is consistent with that. So there's up and down bits on the left, flat bits in the middle, and more up and down on the side. And she's on propofol, so there's no data. So 30, 40, 50 minutes into the case, this is actually a sort of this is a scientific preparation of general anaesthesia and not a patient having surgery. So the next slide. What would you do? Give aramine, watch and wait, decrease the propofol and the REMI, or tell the surgeon to hurry up.
Isn't 5 always correct, Kate?
It depends where you're working, I think. So we'll vote.
So if we can vote on that now, yep. Well, that's pretty much an even spread. So the least popular was decrease the propofol and the REMI. The most popular, and not by much, was, well, it's pretty much level. Aramine, do nothing, tell the surgeon to hurry up. But I think that's a universal sentiment. So Kate, what did you do? What are we dealing with?
Well, I think the principle here is to have all of this information in context. And in neurosurgery, as in other types of surgery, you have to keep an eye on the surgeons. Because, in fact, they were about to put the local with the adrenaline in the patient's head. So you can get lulled into this sort of false sense of security by, you know, turning everything down and, you know, not doing the chart or something, and you don't notice, and all of a sudden the stimulation goes up in a scenario of low hypnotic and opioid delivery. So I didn't do anything because I knew that they were about to do something. So this sort of raises the context issue, which is that you can't just treat the BIS number, you have to treat the context, and the most important variable in the room is the surgeon.
And when they did put or start operating, and you hadn't done anything, what happened to the various bits and pieces, numbers, BIS, cardiovascular parameters?
Well, interestingly, because of the volume of lignocaine and adrenaline that they use, that you see this beautiful adrenergic effect. So the first thing that happened was that the blood pressure went down due to the beta effect, the dilation, and then the blood pressure and the heart rate went up a little bit, not much. So I didn't do anything. Masterly inaction, which is my forte.
I mean, is this a scenario where it's possible that you're running totally on total intravenous anaesthesia, so there are some potential variance in how much is actually in there. This is one where they could have sort of leapt up if the muscle relaxant had worn off when the surgeon started operating.
Oh, absolutely. And the other thing is that in this case, they want the muscle relaxant to wear off so that the facial EMG monitor will work. And 50 minutes later, it doesn't look like the TOF is working, or is naughty, because one should always use muscle relaxation and TOF monitoring together. But yeah, I think to the answer to your question.
Excellent. Okay, well look, I think I'm just aware of the time, and there's a couple of interesting cases. If you don't mind, Kate, we'll move on.
No problem.
Jamie, this is interesting. Can you take us through this?
This is a young lady who was having plating of a wrist fracture, and she was terrified. And so the first picture is before she got her anaesthetic. And so I put in a few labels there. You can see a blink and a lot of this funny spiky sort of stuff happening. So the next slide. So it's kind of unusual for a preoperative EEG, and those are the questions. Well, that's the question, those are the answers.
So what are we seeing? Trembling, sleep spindles, K complexes, epileptiform spikes, or an ECG waveform? If everyone let us know now what they think. You've terrified her, Jamie. She's
exactly,
trembling.
yes.
Is that right?
Exactly, yep. Well, epileptiform spikes do look a bit like that, but in the context, I say they weren't.
People having a seizure.
Exactly, you'd notice that, hopefully. Even I would. Okay, next slide.
Just to comment on that, there's a lot of people talk about epileptiform features on the sort of intraoperative or perioperative EEG, but it's not really. Epileptiform just means funny looking. It doesn't really mean that there's a seizure or that it's anything to do with epilepsy whatsoever. And
I agree. It just means a fast, synchronous thing that's happened. So in this case, it's probably muscles rather than brain.
Whenever you read the word epileptiform in an anaesthesia journal, you really should replace it with just sort of funny-looking EEG.
Yeah, I agree. Anyway, so we gave 100 of fentanyl and slammed in a bit of propofol and cranked up the SIVO. The patient became unconscious, but got very rigid and showed quite a lot of jerking movements of the legs and arms, which I guess you occasionally see in this situation. This time I happened to have the EEG on, which is a bit unusual, and so that was the EEG that you see. So you can see those funny blue fuzzy bits are EMG, and underlying it you can see quite a deep-looking burst suppression kind of EEG pattern, and then there's these large, fast, spiky-looking things around 25. Anyway, the entropy, and I've had other cases with the BIS, said this patient was still awake. So if we can have the questions. So if we say that it's getting a bit hard to oxygenate the patient because they're so rigid, would you be happy to do any of those 5 things?
Okay, so relaxant, propofol, sevoflurane, thiopentone, ketamine. What would you like? Okay, so most people want to paralyse the patient. Quite a few would give propofol. And I guess we hark back to the efficacy in Jim's sort of case, for example. Less people want to give sevoflurane and thiopentone. Jamie, what did you do?
Well, I think this is just an example that you're pretty safe to give a relaxant and the patient won't remember what happens next, because we're pretty happy that the patient is unconscious, certainly amnesic. If you're worried about the epileptiform activity and that you thought it was perhaps more continuous and was heading towards a proper seizure, then you could rationally give either propofol or thiopentone. I mean, I think in this situation you probably want to give thiopentone because it seems like the propofol has kind of initiated this, and there's a small percentage of people who will get seizures with propofol. And I wouldn't really want to give more sevoflurane because it also is a bit pro-seizure-y sort of drug.
Okay, can I ask you, Andrew, in the setting of inhalational induction and sevoflurane and excitatory movements and epileptiform activity, which is a word I can't use now, is there a real issue, do you think, in that space in terms of very high concentration of sevoflurane in children and what's been claimed on occasions to be pre-seizural or seizural activity?
I think to me, it's just a curiosity rather than a problem. Some people get very anxious about it. There's no evidence at all that the child is more likely to have epilepsy. There's no evidence that their post-operative course is going to be influenced whatsoever. The recommendations that reduce the inhaled concentration to 6% makes no sense whatsoever because of the time lag between your end tidal and your brain concentration. So saying you shouldn't give 8% but you're allowed to give 4% is complete and utter nonsense because you never get anywhere near 8% sevoflurane in the brain. So if you're worried about giving too much sevoflurane, then it's the time and the concentration rather than just the concentration that's going to cause a high concentration. But funny looking things that happen with induction with sevoflurane I think are a curiosity. You can call the registrar in and show them, but otherwise I wouldn't bother, wouldn't worry.
I mean, I would say if you worry nitrous oxide opiates or propofol will switch it off pretty effectively. I think that would be true.
And Jamie, some work you did a few years ago, sort of ranking the excitatory potential, I suppose, of some commonly used anaesthetic agents. Can you just remind us what's potentially significant and what really doesn't seem to be any problem at all?
Well, desflurane and isoflurane are the least pro-seizure volatiles. Sevo was kind of halfway between isoflurane and enflurane.
And enflurane is pretty special from memory?
Yep.
Okay. I don't think we can find it anymore, can we? I reckon I'd struggle to find pentothal half the time these days, but that's a different story. Look, we're just about at the end. I just want to rattle through this one, only just to follow up something that we discussed earlier. This is a young woman who had a parietal tumour out, TCI, propofol, some Remy. She's paralysed, or was at some point. But what I'm seeing here is that this is giving me a number of 40, that's fine. This is her EEG trace here. This is another part of her EEG trace at a similar time. And the suppression ratio here is 16. It's telling me. So I was interested in what people thought about this. I'll flick to the next slide. So we have someone whose heart rate's slowish, blood pressure's okay, this is 40, suppression ratio 16. You saw that sort of trace. Is this someone whose anaesthesia in the normal range, too light, too deep, or you're not sure? Could people let me know what they think about that? So it's normal. Most people think, some people are uncertain, some think it's too deep. The only reason I mention this one is that the suppression ratio really is the amount of time your brain is in this period of silence, as we've heard already before. But we've also heard that it can be interference. This is a long period of silence. The suppression ratio is probably 80 or 90%, not 16. But you're seeing interference. In this case, I guess the surgeons were rummaging around in the brain and probably affecting the frontal trace to some degree. But you do see it in other cases as well, and I think we've heard about the suppression ratio and measurements in children as well. So it was, this was an example when having the trace, it suggested to me that, in fact, the suppression ratio was much greater than that, and this patient was actually pretty deep. Just out of interest, later on I lightened them and swapped them over to volatile, and you can see that suppression, burst suppression has disappeared altogether, although the BIS actually hasn't gone up all that much in this particular circumstance. Suppression ratios, it's something really important. What does suppression ratio, what contribution does it make to the BIS number calculation?
It varies with the different versions. So it used to be very strong correlation at low BIS, but the correlation is not quite as strong with the more recent versions. I mean, suppression is telling you that you're poisoning the brain's mitochondria.
You don't see it at 40 very often,
No.
though. It's more usual to see it down around the 30 mark, don't you think, Jim?
Yeah, well, that was my thought when I looked at the first trace.
Yes.
It's an interesting question, though, that you raise, is that do you believe the number or the trace, or how do you put them together? Because 40 is pretty good. 40 to 45 is where I generally aim things.
Yeah, I wasn't sure, actually. I tended to believe that, in my experience, that sort of degree of burst suppression is pretty darn deep as a rule, and usually I expect to see, say with profile burst suppression, coming on at the sort of 30-25 mark is when it tends to come on, whereas this didn't quite line up with that. So I don't know what I was doing different, or the patient was doing different, or the algorithm was doing different, but I was just a little bit confused. But I went with the strengths on the fact that if most of the time the brain was silent, that was probably pretty deep.
So can we reframe ask Jamie to answer the question again, which is why in some people does that trace end up being 25 and in this girl it's 40?
I think that's an indication of that they're artifacts. And so it's picking up, you can see there's little peaks in the middle of the flat bit. It's picking those up and smearing them in time a bit. And so you're ending up with less burst suppression than you think. I mean, I think this is I presume this is quite a modern version of the BIS. I mean, I doubt you'd see this on the sort of XP versions of the BIS. I mean, if you get enough noise, that flat bit can look like an awake EEG, and you might have certainly you'll see it quite commonly with the entropy. So the entropy system only picks up burst suppression about 90% of the time. So about 10% of the time, it will think that flat bit is an awake EEG, and you'll have an entropy of 90.
I've seen
and you really don't want to overdose. You'll kill people if you follow that number.
That happens on cardiopulmonary bypass.
Yeah, and it's probably electrical interference, some sort of fashion.
I'd firstly like to very much thank the panel for coming along. Jamie, Kate, Jim and Andrew, I think it's uncommon that we get such a breadth and depth of experience together, especially the chance to put them under the spotlight and grill them, and also have deep insights into how they practice anaesthesia. So look, thank you very much for coming along. Thank you as a group for participating, because I think it's very helpful for us to understand not only how we all have different opinions about medicine, but how we see the EEG, because despite the fact it's been around for a while, it's still finding a place and we're still learning how to use it. And I would lastly like to thank both the organising committee of this meeting for allowing us to have this session, and again thank Covidian as a major sponsor of this meeting for helping to support this session. So thank you for coming. I think morning tea is probably waiting outside, and please don't hesitate to catch up with our panel if you've got any questions afterwards. So thank you for coming.